Welcome everybody to our webinar where we're going to be focusing on how to embed visual impairment pathways into stroke care using our experience in Greater Manchester. We're just going to let people are still joining, but I'll just run through some housekeeping whilst we start. So you'll notice that you're on mute, which is for a reason to help manage the session. However, we are wanting you to be interactive and ask some questions. We have got a specific panel session at the end where the speakers will be available to talk to around the presentations we've given. So if you can put any questions in the Q&A box as we go along, and I'll pick them up at the end. We are recording this. We do have a YouTube channel. If you look on the chat page, you'll find that there's some links there to our YouTube channel and also our website, which contains the toolkit, which we're going to talk about today, with all the information from today is in, as well as a web page with resources. The links to that are in the chat section. So we will be sending you out the recording in the next sort of 7 days, hopefully by the end of the week, actually, along with a PDF version of the slide set, which will also be uploaded to the website. If you do need a certificate, then Karen, who is sat to one side of me here, making sure that everything goes very smoothly, she's can provide you with one if you just want to email out to her, and just if there's anything else. So in terms of the webinar today, we are here to showcase the work that we've done in Greater Manchester and how we've implemented a visual impairment pathway. We're going to talk about how that's worked clinically and also what that's meant in terms of impact for the wider system. We're going to talk about in fact, we've got two orthoptists here. We're going to talk about the value of their integration into the pathway, and in particular, multidisciplinary working. We've got a very multidisciplinary panel today, and the approach was very much that. And we are here really to raise awareness for the need for visual impairment pathways across stroke services, because at the moment, we know that we are not the only area that has an issue with this. So in terms of today's panel, so I am Sarah Rickard and I manage the Neurorehabilitation and Stroke Network based in Greater Manchester. Joining us a bit later is Farheen, who actually managed the project when she was with the network. She's actually moved on to another role within the trust, but she's an orthoptist by background and is desperate to come back and talk about the project that she was her lifeblood for a while. Then we've got Adam and Sarah from the Stockport Orthoptic Service, along with Kat from the Hyperacute, the Stroke Service, and Rachel from the Community Stroke Service at Stockport. And then we're very pleased to have Simon, who is from the charity, the Visual Impairment charity, Henshaws. So that's our panel today. So I'm going to kick off, just talk a little bit around the just a little bit of background to the project, which was this was the title of it, so Visual Impairment Pathway in the Southern Sector of Greater Manchester. I'm going to tell you where that is in a minute. So just by way of background, I'm not going to labour the point. I'm assuming you're all here because you're interested in visual impairment, and I'm assuming you have some level of knowledge. A lot of what we talk about today, there'll be more information in the toolkit, and there are more resources on the website. So this is a real kind of light touch in some of these areas. So we do know that vision impairment is a big deficit post-stroke, with almost 3/4 of patients having some kind of stroke, having some kind of vision impairment after their stroke. And a big chunk of those are not able or cannot actually report their visual symptoms, so they need to be assessed. And we know that not only in Greater Manchester, but across the country, there is variable access and often very poor access to visual impairment and orthoptic services as part of the stroke pathway. So there's significant unmet need. What do the clinical guidelines tell us? This is a bit of a summary. So the National Clinical Guideline has quite clear instructions for us and recommendations around visual impairment, and so does BIOS. So the standards talk about that people should be screened by people who are professionals with appropriate knowledge and skills using a standardised approach. The screen could be completed in the same period as other therapy provision, and that multidisciplinary treatment programmes should be developed with an orthoptist, and various approaches should be used to maximise their safety and independence, and be aligned with the person's goals and their preferences. In terms of stroke in Greater Manchester, we operate what's called a centralised pathway, which is similar to one operated in London, whereby most of our patients are picked up by ambulance and they're taken to one of 3 hyperacute services. And the one we're talking about today is Stepping Hill, which is the one at the bottom right in terms of the colour. And that they each serve a different part of the conurbation. Patients are then treated, they're either repatriated back to their local hospital, or if they're a resident, and that's what we're talking about today, Stockport residents, East Cheshire residents, they remain and get moved to stroke rehab wards to receive their rehab. They're then discharged, and we do operate an integrated community stroke model across the whole of Greater Manchester, so they will be seen by a specialist team for as long as they need, and then they're discharged and are supported by life after stroke services. In terms of the challenges that are faced in terms of vision impairment, these are probably not unfamiliar to you. That's hopefully why you're here today. So we had lots of variation in terms of screening and referral pathways, patients who weren't being consistently assessed. There's gaps as well in community, so there's lack of access to orthoptics and lack of screening. We don't record much information on this. We're not tracking patients, we're not collecting data, and our workforce are often not upskilled as we would need, and they don't have confidence in this part of the care pathway. So in terms of the project, so I don't know how many people on the call come from the stroke world, but be aware of Squire. So NHS England ran the programme where they funded projects that were based around community rehabilitation and life after stroke. I think it was between sort of 2022, 2023, where they awarded project money, pilot money, to a number of different projects. We were successful in one for vision impairment pathway. And the aims of the project were to establish a pathway in the southern sector. You'll see a map there of Greater Manchester. And for those of you not in Greater Manchester, I'm feeling with the Andy Burnham situation, you're going to learn an awful lot more about Greater Manchester than you ever wanted to. Makerfield, by the way, is off to the left of the picture in Wigan. We're looking at the other side of the city down, or the conurbation down in the bottom right. So we have we were aiming to set up a pathway that would serve this sector of our area for stroke survivors, and we were looking to address the gaps in the stroke services in the community teams and also in the Stepping Hill hyperacute stroke unit that serves that region. And the idea was to get timely specialist assessment and onward management in line with the clinical guidance. Just finally, before I pass you on, the project was funded, and what was that? The intentions of that were to fund staff, equipment, to help develop the pathway, and also to coordinate the project. So the Stepping Hill Orthoptic Service, the stroke service was born. There was a specialist team, which Adam and Sarah are going to talk about. Then there was going to be some funding for some equipment and also some OT post fundings in the two community teams to help develop pathways and to provide extra capacity whilst we set the project up. And then Henshaws were provided with funding that Simon's going to talk about for an ECLO post, which he's going to talk about. And then finally, Faheen, who is going to join us later, was funded to manage the project. So the network oversaw and managed the project on behalf of the other partners. So we work very collaboratively. So that's me done. I'm just going to pass on now to I think it's Adam just to kick off with, and they're going to talk about the setting up the orthoptic service at Stepping Hill Hospital.
Right. Morning, everyone, and thank you, Sarah, for that. My name's Adam Budd. I'm the lead stroke orthoptist at Stepping Hill. I'm here with Sarah Lee, who's our advanced stroke orthoptist, and together we'll be running through the orthoptic setup for this project. So we started with the pathway development. It was a multi-professional and co-productive development. Multi-professional in that alongside myself and Faheen as project lead, we created this pathway with our inpatient and outpatient therapies teams and Henshaws. And we co-produced it alongside some stroke survivors as well, using their insight and experience to help shape how we created our pathway. We also spoke with some trusts around Greater Manchester and East Cheshire to create the network so that we can basically communicate with them with regards to repatriating the patients. We used recommendations of national guidelines, which obviously Sarah's touched on, through NICE and also the Royal College of Physicians to help shape the pathways. I also made sure that we were compliant with the SNAP data requirements so that we could highlight the orthoptic involvement within the stroke service. Our orthoptic assessments were delivered to all new stroke patients. We followed the SNAP guidance to make sure that we got it done before discharge, but we're very mindful of the literature to ensure that we did try to make that 3-day assessment where we could. However, not all patients could receive an orthoptic assessment before they were discharged. And in those cases, they received a visa assessment by our fabulous occupational therapists, both inpatients and outpatients where necessary. And we collaborated with the British and Irish Orthoptic Society Stroke Clinic Advisory Group, as well as orthoptic departments around the Northwest to help gain sort of further insight and guidelines to shape what we did. We also worked alongside the lead stroke advisory group for BIOS, who very kindly gave us her time to competency assess us and give us training and further advice. So we also created some standard operating procedures from all of that information, and we also created some additional departmental training and competencies. We also developed ourselves further using the likes of the wonderful stroke study days from this network. We're also very mindful of the fact that there is a lot of additional NHS targets to be met, and we try to sort of be quite modern in our approach with this in terms of digitalisation of the NHS. And we created an electronic patient record system for all our patients, inpatient and outpatient. We utilised databases to track our patients, so to see those who needed to be seen, those who didn't, as well as gathering information for clinical audit and also the project metrics. We tried to use online patient information leaflets where we could, and also apps for gaze training and exercise prescription. We're mindful of the greener NHS targets as well and try to cut down on our use of paper and plastics. And in outpatients, we try to sort of utilise social prescribing where we could as well. But above all, we try to ensure that we had a patient-centred focus around what we did, and we're very adaptable to everything that we needed to do and change if necessary. So then on to the orthoptic team. We put out a national advertisement for what was essentially added up to 1.8 whole-time equivalents worth of orthoptics as per the British and Irish Orthoptic Society guidance in stroke. That led to a number of applications, but we ended up with the positions of the post being filled by internal applicants. Myself as the lead, Sarah, who are Band 7 advanced stroke orthoptist, and then Amira and Naeem as our Band 6 orthoptists. It's been wonderful that we could obviously upskill ourselves, and obviously now we have 4 additional orthoptists that are trained in stroke and being upskilled at Stockport, and I'm able to maintain our links with the stroke team here in Stockport. The downside to of all being seconded was that we had to wait for some backfill before we could be sort of let loose on the stroke wards, really. So that was just a bit of a downside on that was all. So I can move on. But advantages that we feel that we've been able to give to our patients is that we've been able to be very sort of timely with our diagnosis and advice at the acute phase of stroke, which has been very helpful in being sort of to target any sort of therapy that we can offer, and indeed advice to the patients, their family and the team. Obviously, understanding their visual needs hopefully has led to a reduction in falls. We've also been able to reduce the anxiety of the patient as well. And it's been wonderful that we could share our skills and knowledge with the multidisciplinary team, both inpatient and outpatients, but also very rewarding from our part to be a part of that team and actually learn so much from them regarding these patients. So I'll hand over to Sarah.
Good morning, everyone, and thank you, Adam, for that. So I'm going to talk about what our Envision service looked like in practice. So for our inpatient service, we aimed for an orthoptist to be available from Monday to Friday. The orthoptist was also involved in weekly multidisciplinary meetings. The occupational therapists, physiotherapists and healthcare assistants that worked on the ward shadowed an orthoptic assessment. This gave them a better understanding of what the orthoptic assessment entailed, and it also contributed to the longevity of patient care. The orthoptist also delivered a training session with the physiotherapists and the occupational therapists on the ward. So our service for the outpatient clinics The greatest challenge we had was securing a base to run the outpatient stroke clinics from, and this stemmed from the closure of outpatient B and delays in clinic relocation. So we did run outpatient clinics, but from Tameside Hospital between the months of March to August 2025. These clinics were ad hoc depending on the availability of the clinic space. Initially, there were 40-minute appointment slots for the month of March. We decided on 40 minutes to address the delays in follow-up and also to address the waiting list. The orthoptist felt, though, that 40-minute appointment slots wasn't enough time, so for the remaining clinics, we increased that to 1-hour appointment slots. There were 24 sessions in total and 62 appointment slots were utilised, and an ECLO was also available at these outpatient clinics to run alongside our clinics. We also set up 2 sessions at the Cavendish Hospital in July 2025. Again, these are 1-hour appointment slots and 4 appointment slots were utilised. We also had the orthoptic consultation session, which ran weekly, liaising with the outpatient MDT team, which we could provide advice and also better working relationships and communication. So the assessment itself, I've divided it into the inpatient and the outpatient assessment. You can have a read through of what the assessment involved there. Our formal inattention and neglect assessments were the same as is in the visa screen. We decided on that so that there's continuity if a patient was seen, was screened with the visa screen and then seen again in outpatients. These included the line bisection, the drawing of the clock face and the clock cancellation. We also had informal visual inattention assessments, which included observation in free space, function and room description, and visual fields to confrontation was done on the ward. The outpatient assessment isn't that dissimilar from what we did for inpatients. However, it did include the binocular estimate using the Humphrey or repeat of the visual field to confrontation depending on the patient capabilities. And we also had access to other specialised equipment such as the Hess chart and the Synoptophore. So the management is what I'm going to talk about next. So inpatient and outpatient, we had a patient-centred approach to offer a more impactful and targeted treatment plan, and also gave a better positive patient experience. You can have a read through of the different management there. For the outpatients, we also gave more advice regarding the visual impairment and what that means to them long term. We offered CVI registration. We could link in with the ECLO and also had a look at exceptional circumstances to returning to driving and hyperscopes.
Sorry, so back to me just for the final part really is that we did face a number of challenges whilst we ran this service, particularly as Sarah's highlighted with the closure of our outpatients B, which meant we had a lot of relocation issues and things put on hold. So that unfortunately meant that our outpatients ended up having to be seen elsewhere, or very kindly seen elsewhere, with other teams allowing us to use their facilities. And also just that lengthy recruitment process for staff. It was brilliant that we are able to second and upskill our own staff, but did mean a bit of a delay just getting onto the ward with the project. So final slide, Sarah. That was a very quick whistle-stop tour. That's my email address. If anyone does have any queries or questions that aren't answered in this webinar, you're welcome to take my email and email me. Thank you.
Excellent, thank you both. We will move on. I've just put, if you have got any questions, stick them in the Q&A rather than the chat, please, but I'll monitor both. Moving over swiftly then, we've got Kat from the inpatient stroke service at Stepping Hill Hospital.
Thank you, Sarah, and thank you, Adam and Sarah, for that. So I'm going to talk a little bit to you today about what vision assessments looked like and what the pathway looked like prior to the Squire project, and then a little bit about the impact of the project and the legacy. So our stroke pathway prior to project was that all patients admitted to the stroke unit have an assessment with by an occupational therapist within 24 hours of admission. That assessment would vary very much depending on the medical status of the patient in terms of how much we went into depth, but over a period of appropriate time, patients would be assessed in relation to cognition, vision, sensation, proprioception, and their functional abilities from an occupational therapy perspective. So as occupational therapists, we would assess vision with standardized and non-standardized methods. So traditionally we would be looking at non-standardized, so functional assessments, for example, a kitchen task observational assessment. Is the patient able to locate items? Are they missing items on one side? Are they scanning when walking, or are they walking into obstacles? Overfilling cups, are they picking up items effectively, or does it look like they've got depth perception issues? We would look at assessment of oculomotor movement and assessment of visual field through confrontation, and also their ability to read and recognise pictures. And we have various visual perceptual assessments to identify spatial inattention. We did use here at Stepping Hill a visual screening process, which looked at similar areas to the visa, which was later developed, that one of our occupational therapy clinical leads brought from another INRU unit. So moving on to the standardised assessments, we would look at we started using the visa tool, which was developed by Claire Howard, and we'd seen that presented at one of the GM conferences. So we started introducing that within our team, and we also utilised the Oxford Visual Perceptual Screen. So the referral pathway prior to the project, obviously the guidelines indicate that all patients should have an assessment of vision using a standardised tool, hence our introduction of the visa tool. So the OTs were striving to achieve this standard in the absence of any specialist orthoptic support. If we identified visual deficits, our pathway was that we would have to request a referral to ophthalmology as an outpatient, and that was via a consultant-to-consultant referral. If they had a visual field deficit, that may not be initiated until 6 weeks post-stroke. If it was diplopia, it would be initiated sooner, but patients often did sit on the ophthalmology waiting list. And once the referral was accepted by ophthalmology, they would pass on to our orthoptic colleagues if they felt this was necessary and required. So if they were seen by ophthalmology or orthoptics prior to discharge from hospital, we would be able to read and interpret their entries from the medical notes. There was very little communication between departments for advice. So the OTs would educate and advise patients on strategies to compensate for those visual deficits, including scanning techniques, techniques for reading, use of eye patches for diplopia, but this was very much based on functional and clinical presentation as to whether it was beneficial. And then at point of discharge, we would refer to our local community stroke team, and we would identify if vision was impacting on their functional abilities. There were some inequalities for onward referral in terms of access to specialist visual services. So our Tameside residents were able to access orthoptic services in their locality, but we had a lack of specialist services following discharge for Stockport and East Cheshire residents. So this is just the pathway that was developed from the toolkit. So you can read that for yourself in there, but basically the orthoptist would screen within 3 days of admission. The role of the OT was to cover the weekends because the orthoptists were only commissioned for a 5-day service. So we would carry out the visa tool as a second line option. And for those occasions where we were not able to do that due to operational difficulties, we would email the general stroke orthoptist email to give them a list of people that required screening, and also make our community colleagues aware on the referral on discharge. So what was required to implement the pathway, and how did it actually work in practice? So all the occupational therapists required training to undertake the visa screening, so that could be done at weekends and when orthoptic cover was unavailable during the week. The email handover to hand over those patients that we hadn't been able to screen. The orthoptists were embedded within the MDT, which was fabulous. It gave us immediate access to expert advice, support for the team, patients and relatives, enhancing their care and helping to manage expectations in relation to prognosis. And that was invaluable, not only for the patient's well-being and to support their rehab, but also when we were coming to point of discharge, where relatives might be extremely anxious. We have a lot of expectation management, and our orthoptics colleagues were fabulous in being able to talk to patients and relatives specifically about their visual deficits, which was really reassuring for them. So training was provided by the orthoptics team to enhance the occupational therapist's understanding of post-stroke visual impairment, the various different clinical presentations and the complexities of those, and to enhance rehabilitation. The therapy assistants received training also to make sure that they were able to carry out those rehabilitation programs, and training from Henshaw's to increase the whole MDT's awareness of the impact that visual impairments post-stroke can have, and also signposting to available community support. So the project legacy, we all have a greater awareness across the teams of post-stroke visual impairments and the impact on driving, mobility and visual considerations, and they are now consistently embedded in rehabilitation planning and risk management. The MDT workforce has been upskilled, including following the end of the project. We have now upskilled our therapy assistants to carry out the visa tool as well, so that we can offer that to more of our patients, even at times of operational pressures. We have a strengthened visual screen within the inpatient service, which means we're aligned with the SNAP targets. And we now have a direct referral route from inpatient therapies to ophthalmology consultants for visual field issues and advice, and a direct referral route for orthoptics for diplopia following confirmed stroke diagnosis, which is amazing that as AHPs we can put those referrals through and don't have to have that consultant referral. We also have a library of vision resources to support and inform patients and relatives. And we have an occupational therapy vision champion to maintain the focus on vision post-stroke, as well as those professional links with our orthoptic colleagues. Although they're not present with us on the ward anymore, we know where they live now, and we can pick up the phone, call them for advice, get them involved, which is brilliant. Our OT Vision Champion also reviews current evidence-based practice and keeps an eye on any upcoming training, so that she can then cascade wider training regarding things like visual processing difficulties post-stroke. And this is just, it might be a little bit hard for you guys to see on the screen, but this is just something that we developed for vision with regards to our therapy assistants carrying out visa screenings. So we've just done a little bit of a flow chart to make sure that those patients that are being screened by a therapy assistant are appropriate to be screened by them, because obviously they're completing a screen, not interpreting an assessment. So anyone who comes in with obvious visual deficits, cognitive deficits, other complexities are screened by an occupational therapist using the visa tool, and our therapy assistants screen those more straightforward patients, which means that we're just checking and picking up on any non-obvious visual impairments that we might otherwise have missed. Thank you very much.
Fantastic. Thank you very much for that really comprehensive overview of what happened in terms of the inpatient service and the work you did. I'm going to move us on to the community side of the pathway. I noticed in the chat, so the visa tool has been mentioned a number of times, and I think we are lucky to have Dr. Claire Howard on the call. She is part of a wider collaborative, as mentioned, that's led by Fiona Rowe in Liverpool, who we work very closely with. So I'm sure if you have any questions about visa, then she's probably going to be able to answer those, and might bring her in terms of some of those questions if there are any. So just to move us on as well, and just to say as well, ECLO, if you don't know what that means, it's an Eye Community Liaison Officer, and Simon's going to talk about that in a bit more detail in a bit, but I just thought I'd drop that in now. So over to you, Rachel.
Thank you very much. So as we said, I'm Rachel. I am one of the occupational therapists with the Community Neuro and Rehab Service within Stockport. So I'm going to take you through the CNRS participation and engagement in the project. So as Kat did with the inpatient service, we'll provide you with a bit of an overview of the pre-project pathway. We'll look at the activities around the implementation and the outcomes and benefits that we've achieved from the implementation of the project. Okay. So prior to the project, referral information from the inpatient service was often limited. It was unclear whether vision had been screened at times, and if so, what the outcome was. Where the information was provided, it was not always evident whether the findings were based on a sort of subjective report from the patient, whether there was formal screening involved, or if it was through observation during a functional activity. Referral forms were often left blank, making it difficult to know whether any screening had been taken place at all. Information regarding onward referrals from inpatient services to ophthalmology was also sporadic, and if it was often unclear whether a referral had been made. And for us in the community, it was very difficult for us to obtain that information sort of post the time. So a patient would then be seen for a holistic screen assessment that could be carried out by any member of the team. And we relied very much on the patient self-reporting any visual difficulties or changes post-stroke. If it was self-identified, then they would be referred to the occupational therapists. However, within the pre-project pathway, onward referral for further visual screening was inconsistent, even in cases of a posterior infarct. So basically, if it was not self-identified, it was rarely highlighted as a need. So then they'd be referred on to occupational therapy assessment if a VI was identified, and the assessment would typically include an more informal screen rather than a standardised assessment. This generally covered oculomotor control, visual fields, and a visual perceptual screening tool such as the Oxford Perceptual Tool, alongside obviously our observations within function. Visual impairment screening was not standardised across the team, and practitioners reported varying levels of confidence, particularly in relation to the driving pathway, which is a big side of what we do in the community. Screening often relied on skills and approaches that had been drawn from clinicians' previous experience rather than the use of a consistent tool. Our access to ophthalmology from the community was very challenging. Referrals from community therapists were not accepted, meaning we had to request the GP to then refer on to ophthalmology. And that often caused some inconsistency because that request wasn't always followed through. Waiting times for ophthalmology were frequently lengthy, which had a significant impact on especially on our driving population, and their ability to return to their previous levels of function. This led to financial and emotional consequences, and in some cases limited our patients' access to other rehab opportunities, such as the group rehab activities that we run as a service. What we were finding is there was also no consistent feedback mechanism from ophthalmology as to the results and the advice that the patient had been offered. It's worth noting that prior to the project starting and in line with the stroke drivers pathway, the team had begun exploring more direct access into ophthalmology. Whilst RCOT guidelines highlight that OTs can provide expert specialist assessment and intervention for people with VI, many of our therapists felt that the level of responsibility associated with assessing this, in particular related to the driving population, it was very significant and beyond their confidence to be giving the advice as to whether someone can return to driving with the post-stroke VI difficulties, or with highlighting those difficulties. So CNRS involvement, what did we do? So we jumped at the chance to be involved in this pathway because we'd identified it as a need within our service. So we needed increased hours to implement the project. We needed to upskill the team in terms of knowledge and skills, both in the assessment and identification of VI, as well as the treatment, advice and support given. This includes the team nurses as well as the OTs. We looked at the equipment and resources that we would need, and we carried out a process map of our current pathway to identify scope for change, and then we mapped what our desired pathway would look like and what we felt would work for us. So in terms of the implementation of the project, from a recruitment perspective, as Adam was talking about, there were delays in recruitment, meaning that the posts didn't commence until well into the project. During the implementation phase, we found that our waiting lists increased, reflecting the time that was required to establish the new pathways across the team, as well as the need for training and embedding new ways of working. Once in post, the recruiting staff significantly supported the recovery of these waiting lists. Significant focus was placed on training and upskilling. This included myself attending the orthoptist training at Liverpool University. We had the orthoptists, Adam and Naheen, come in and train us on the visa, the nursing staff and the OTs on the administration and interpretation of the visa. And then the whole team had awareness training delivered by Henshaws, including the role of the ECLO. And this kind of enabled onboarding from the whole team and enabled engagement across all disciplines to support the project and with the outcome of the data collection. Improving information transfer across the pathway was also a priority. Although vision screening and identification were more consistent at the acute phase, the information was not consistent, still not consistently coming through to us. So we collaborated with the orthoptists and the acute therapists, and we adapted the Greater Manchester referral form to specify what information would be beneficial for us to receive for the patient on that part of their pathway. It also included information on the referrals to ophthalmology, and we found that this was then consistently communicated once that referral form had changed. In terms of pathways, we had a new local team pathway for those who'd been identified as not having been screened within the inpatient setting, and we found that those were very few and far between. For instance, those that had gone into hospital on a Sunday where there was no OT cover, and at times of, as Kat said, the organisational pressures. We had simpler and more direct referral pathway to orthoptist services and to our ECLO support, and we reviewed our driving pathway in light of the project. As Sarah and Adam have also talked about, we included greater MDT collaboration. So the orthoptist attended our CNRS MDT and goal setting meetings each week to join with patient-specific discussions, and they were able to offer advice and support on a more consultation basis as well. Having their presence in our office was really beneficial to be able to have those discussions. We identified opportunities for joint working at the beginning of the project, for example, the OT to attend orthoptist outpatient clinics for more complex patients, or those that would benefit from that joint approach. So those with concerns with returning to driving and also concerns with returning to work. But as we've heard already, the community aspect of the delivery of the project was challenging due to the closure of Outpatients B. So although the intention was there to have those joint clinics, we weren't able to make this element work effectively. We also reviewed and updated the way we recorded goals and outcomes within our service. So the benefits of the project from a pathway perspective, whilst the project was going ahead, we found a significant improvement in the early detection and commencement of therapy. So with this patient group, the carers had already had education and advice. The patients and carers had had education and advice before coming out of hospital and had commenced therapy with visual impairment activity books. And we noticed an implementation of the scanning activities and strategies within functional activity that transferred to the home environment. We had improved communication, emotional and psychological technological support from Henshaw's to complement our therapy input, increased knowledge and skills, just general increased confidence, and as I said before, those NDT links with the orthoptist team. From a workforce perspective, there's definitely a feeling of increased knowledge with assessment and treatment of VI. It was built confidence in the clinician's own skills and their clinical reasoning around VI, and increased skills in the ongoing management of our patients with an identified VI. And this meant that we could offer a broader range of interventions to meet the patient's needs, which are all outlined on this slide. I'll just let you have a quick read of those. Okay. So the key impacts post-project from a service perspective, we know that the VI pathway has not been continued beyond the pilot due to NHS funding constraints. However, we've had clear gains that have been made and core elements have been embedded into our routine practice. As we said before, the information from the ward is clearly highlighting if an assessment's been completed, and if not, then we are prioritising when patients come out into the community. We've noted that as a result of the projects, the difference of information coming from Stepping Hill Hospital versus our other referring hospitals is vast. And we're aware that if we receive referrals from any other acute settings, then it's unlikely that a standardised vision assessment will have been done. Vision assessment, interpretation and treatment is now an integral part of the training package for any new clinicians joining the team, and that's so that we can ensure proficiency and consistency across the team. And I think it's also important to recognise the value the project has added to us as clinicians. And I'll just leave you with a bit of feedback that I've had from one of our OTs within the CNRS on how it's impacted on her approach to patient care. Thank you very much.
Thank you, Rachel. I'm going to cover a little bit later just some of the impacts which have been mentioned, and we've got some great feedback. But I do think the impact isn't just on the patients; it is also on the professionals delivering the services. So I'll move us on. I'm going to encourage you to ask some questions. I'm hoping that we're delivering such a brilliant presentation that there aren't any, but it would be good at the end to have a discussion with some questions. So please pop them in the Q&A. I'm just going to move us on to Simon now. So as part of this project and as part of the ethos of the network, actually, we work really closely with our voluntary sector services, and having them as part of our care pathways is really important. The NHS can't and shouldn't be doing everything. So we were delighted when Henshaw's, who are a specialist charity, wanted to get involved. And so I'm just going to hand over to Simon, who was involved in the project.
Thanks, Sarah. Yeah, so we supported the project with an eye clinic liaison officer, an ECLO. You'll sometimes hear the C being changed for all sorts of locations, eye care. There's lots of different places. So our service overview was to provide 12 months of community ECLO integration into the pathway, supporting the Stockport residents post-stroke with sight loss. The key to this was identifying the sight loss in the first place. We intended to deliver this with a specialist stroke-informed ECLO. We have quite a few trained ECLOs at Henshaw's throughout MREH and around about the local community, but we got some specialist stroke training as well, which made Sam all the more aware of what she should be doing and looking out for. Our core offer, as always with Henshaw's, is information, advice and guidance, IAG. We provide lots of emotional support, and it's a referral into wider services for us, because you've got to remember this is after the event. This is when someone knows they've got sight loss. So we're trying to find solutions now for people, but our aim is to improve independence, well-being, and access to support. So our specialist integrated role, the ECLO contribution. So our RNIBs are all accredited. They have a specialist role. We work to the RNIB's quality assurance framework for ECLOs. They also take the training as well from the RNIB. We insist on strong multidisciplinary working, and you know, we linked in immediately with the orthoptists, the community teams, the stroke services, the hospital. That's important really, to have everybody understanding what's going on. We delivered quite a bit of stakeholder training and awareness. We find in everything we do, if we can get some awareness training into people, it starts to make sense. It makes sense of the impact that the sight loss is actually having. We like to contribute to the pathway development. We did quite a bit of service promotion, and cross-sector collaboration is always key to us. A couple of barriers, as we've already heard. You know, recruitment challenges across the wider system was a problem. The ophthalmology building closure, which was a real hindrance, really. Limited community venues, as we all know, with any setting, trying to find the space is the big problem. We looked at early ward engagement, and we really discovered this wasn't effective. Some of the adaptations that we made in the end, we transitioned to a hybrid delivery model, which we've done before. It really worked quite effectively. And eventually we relocated the face-to-face clinics, which is obviously our preferred choice. Our delivery model, so what worked? So our hybrid approach, really good. At Henshaw's here, we work with about 4,000 people with sight loss a year across Greater Manchester, and we already know that a hybrid approach works. People like phone-based support because we take the support to them. We don't ask people to engage with the support. We're very proactive. But face-to-face clinical post-orthoptist appointments are the pinnacle, really. If you can get to that, that's where you need to be. Your person's there. You're not trying to catch them on the phone. So these are, you know, your ideal sort of thing. It's far better assessment and advice session. The clinics at Tameside General Hospital, we were looking at 2 sessions a week, three patients a session. And like I say, if we can capture people after the orthoptist assessment, that's the best time really to catch people. We've got, it's okay. Immediate post low vision appointment engagement. This improves your intake and your uptake, and it is the best place. Patient engagement. So we had 228 patient referrals over the 12 months, 206 via the orthoptists. There were 14 community referrals, 8 ward referrals. We actually, after that, we had 158 patients engaged. We talked to lots of people with all of our services at Henshaw's. Some people choose not to engage, and that's perfectly right. That's up to those. Our activities, we delivered 126 initial phone appointments. So our initial phone appointments cover information, advice and guidance. Everybody who engaged with this process was given a IAG booklet. We do this for lots of people that we work with. We give them a piece of information that covers the 10 things you should be thinking about doing if you start with sight loss. So it's a bit of a checklist, but it has all the people you need to be contacting. We did 40 face-to-face contacts, which were really good in the clinics. And then we also conducted another 87 follow-up calls. We find that some people like a follow-up call. What we tend to find with most of our services with visual impairment and giving people some independent skills, the need tends to evolve. So as we get people moving towards independence, they then decide, if I can do this, then maybe I could do that. And so we see this evolving need across most of our services. Some additional insight, with 56 patients were unreachable, and we had 32 just declined any support. So it's interesting what the choices people make. Some of our key referral routes though, so part of the ECLO service isn't just about us talking to people, it's about making sure we get people to the right services that are also out there. We find a lot of the time with people with sight loss, they're not aware of what's available because realistically speaking, why would you be? It's new to you. But one of the key referral routes for everybody with sight loss should be a sensory team assessment from the local authority. This looks at daily living skills, mobility, communications. We make lots of referrals for welfare and benefits support. It's quite interesting that most people, their initial thoughts are about finance. So we can get them in touch with specialist financial advice, you know, and maximise their income as well, which is quite important. We make lots of referrals to an organisation called Sightline as well. This is a befriending service that's across the north. This service links and pairs up people. So if you've lost sight through stroke, then they'll try and pair you up with someone in the same situation who's gone through that experience. So it's really good for peer support. People like this. It's important to people. Walthieu House is the local sight loss support charity in Stockport. Henshaws has a strict policy of not really duplicating any services, so we would immediately try and make a referral to Walthieu House for local specialised sight loss support and peer support. And obviously the Stroke Association played a big part in ensuring that we got people to the Stroke Association and, you know, sort of ratifying why it was important for patients to engage with all of these referral routes. So one last piece, we've got Mr. P. He was a case study. He was living with complex sight loss post-stroke. So they just got to remember, this is on top of all the other issues that, you know, that the stroke had brought. He was diagnosed with melanopia, he had cataract, he had macular degeneration as well. He was basically struggling with daily tasks. He'd got reduced independence. He reported low mood, he reported isolation, he'd limited local support networks as well. So our ECLO intervention for this chap and for many others, it's a person-centered conversation, identifying the key challenges. Alongside that tends to come some emotional support. We measure emotional support at Henshaws quite a lot. A third of our interventions contain emotional support of some kind. So we give emotional support, reassurance, and, you know, that's sometimes all people need. You know, we have a specialist counselling service for sight loss at Henshaws. You'd be surprised how many people just need to talk to somebody about it. We gave him some information, some advice and guidance, just tailored to what he actually needed. The referrals he received, though, were he actually got some digital support so he could access his phone. So this starts to open up a communication route for people. He had a referral to the sensory team. They came and did some assessments for home adaptations and his mobility. So you've got to remember, this isn't mobility, physical mobility. This is his mobility connected to his sight loss. So that's about mobility training. We also got him in touch with welfare and benefits support because he was struggling financially. And he also engaged with the peer support. So he started to work with Sightline, the befriending service. So his impact, it got increased confidence, his emotional well-being improved. It improved access to practical support, which he engaged with. He had greater independence at home, and he'd reduced his isolation, which was key to him. So his statement really, at the end of it, says it all. I'm not sure where it would have been if you hadn't called. The whole point of our service was, let's identify the people, then let's get them in touch with the services that can actually help them. And that would be me, I think.
Fantastic. Thank you very much. We're actually on time as well, which is splendid. It should be said as well that we did have the Stroke Association, who are commissioned for their stroke recovery service across across all of our localities as well. They were engaged and they were aware, so that they would, as part of their service offer, they would be aware that we're doing this and be and have more of a knowledge about visual impairment too. So it's great to have the charities involved. I'm just going to finish up just talking a little bit about the project outcomes, some of which have been touched on already, and then we'll move to some questions. I think some of the questions might be answered by some of the things I say. So in terms of the data that we looked at, there's more information in the toolkit. I'm not going to go through this in great detail. Have a look in the toolkit, and I know that people will be happy to answer follow-up questions if you have about that. So 1,309 patients in the data set, and in terms of their gender and also their age, it was in line with what you would expect for total the stroke cohort that we would see. I'll talk about the limitations of the data, but we didn't record stroke type consistently, so we haven't included that, but most were ischemic strokes. In terms of the visual impairments identified, just under half were identified with a visual impairment, and there were a wide range of deficits that are consistent with post-stroke. Many of these were previously undiagnosed or they weren't managed, so that was important that they were aware of it. You can see from the list there, a lot of people had more than one deficit, so that's why that table's presented as it is. But the top three were reduced vision, visual neglect, inattention, and heminopia, which I don't think I pronounced correctly. I won't even try the next one. As I said, there's more information in the toolkit. Driving, as was alluded to, is obviously one of the main issues related to sight loss and visual impairment. So we recorded data on that, and just under half of the patients that in the cohort were drivers, and of those, almost all received documented driving advice from the specialist orthoptist during their inpatient mission, and then a few others were picked up in the community. We had a lot of discussion before we started the project around data collection, and it's important to emphasize this was not a research project, it was an evaluation, and there was a limitation in terms of how much we could ask teams to collect and what was already being collected. So the data set is not perfect, and I'll talk about that next. But in terms of the outcome measures that we did use that related to activities of daily living, etc. So we use NEEDLE, which is the Nottingham Extended Activities of Daily, I can't even say it, ADL scale, and also the Bartel Index. And we did see changes in the scores, but I will talk about the limitations in a moment. And so there were improvements, and as well, that was seen in the modified ranking. Interestingly, our median length of stay was actually longer than normal, and we're not quite sure why, because you would have thought if you're identifying vision impairment that actually it means you can support people better, but that didn't appear to be the case. But as you will hear, as you've heard, the project was not fully enacted in terms of the management part of it. So although we assessed, we weren't necessarily always able to follow up with that. So that potentially has impacted it. So as I said, we did have some incomplete data sets. We were collecting data through inpatient services as well as community services. That data set I've just talked about was community. And also, as Simon has presented, there was some data around the Henshaws and what the Henshaw service provided. The vision measures the measures we used weren't vision specific either, and also that there was potentially an issue with ceiling effects. The starting points were quite high, so that's one reason why we may not have the data has to be treated with a pinch of salt. We didn't have a comparator group. This was not a research project, and it's very difficult to attribute the impact of the screening assessment with the scores. So we've collected data. It's certainly the diagnosis of vision impairments was useful, but I think in terms of the impact on people's lives and what that then meant, we definitely would need further investigation. In terms of staff feedback, as was alluded to earlier, it was very positive, and there's some quotes there. So people talked about working as part of a team and collaboration and building relationships, and also that confidence about having specialist advice from orthoptists made a big difference, and the input really was invaluable, I think, in upskilling people, but also building confidence. And almost all of the respondents, I'm not sure why it wasn't all, wanted the pathway to become routine practice. And you've heard that elements of that now are embedded in routine practice. In terms of service users, I've repeated one that Simon's presented, but also family members. I think it was around supporting them and something that's it's often neglected and often misunderstood, and actually people understanding what their problems are, it does help people to deal with that and to move forward. So we weren't able to again to do a full evaluation, but we've got some case studies that clearly indicated that service users valued that, not only the patients but also the family members. We talked at various points just around kind of the different impacts, which are definitely around better integration and communication between the teams we talked about, but also ophthalmology services and other services that patients might be referred on to. Really good examples of multidisciplinary working, different types of therapy, different types of orthotic specialists, and also integration with community specialists as well, and voluntary sector organisations. So there really was a collaborative approach. And I think just in terms of supporting patients, that we were able to offer a wider range of support than currently, and I think we've obviously gone through some of the deficits, which I'm sure are represented across the across other parts of the country, and that's upskilling of staff and confidence. That is one of the legacies, but that was a big focus of the project, making sure that the professionals involved had at the basic level had more awareness, but also if they were involved in the pathway, they had specific training. Challenges, so we've sort of touched on this. So the project, it was not delivered as envisaged, and that was mainly due to we had difficulties recruiting to the orthotics team, which held things up in terms of moving forward. And then we had RAC was identified, I think, at Stepping Hill Hospital and shut loads of outpatient services, and we were caught up in that, and there really were very limited alternatives. So we did problem solve. I think it was Farheen who came up with the idea of perhaps running some clinics at Tameside, but it wasn't as we envisaged. We identified lots of patients, but then we had to add people to waiting lists, and we weren't able to provide onward treatment as we would have intended, and that was unavoidable. We worked very hard to try and mitigate that. So and then we didn't end up buying the field machine. I'm not even sure I've pronounced that right, but we weren't able to buy the equipment either for various reasons. So, but we did deliver the project. We just didn't deliver it entirely. But I think in terms of the learning, that's why we wanted to share it with you, because there was an awful lot of learning in there, and there has been some things that have been sustained. So the Squire project, and this might answer one of the questions. So the Squire programme was only ever there for pilot monies, and you'll be aware that the NHS has pilotitis. We have pilots for everything, which is often a surrogate for putting into practice something that we probably should be delivering anyway, but it's a way of getting some funding to get it going. We did hope that we would be able to continue with the service, particularly the stroke orthotic service that was set up, but unfortunately we weren't able to continue with that. So the service at the moment, the orthotic service is not providing the same support, and the Henshaw's part of it has also stopped. But I think, as you've heard, some elements of that have continued, and there remains improvement in terms of patients' experience of visual impairment and the diagnosis and management of that wasn't there before. So these are listed. We've got more direct referral routes, we've got strengthened screening, and we've got greater team awareness and understanding and confidence, I think, in dealing and managing with patients as they come through the stroke pathway. So I think we'll stop there. I think we've all kind of reached the point of finishing our presentation. So any questions, please put them. I'll go to that now. Just to say, I keep talking about a toolkit. We do have a lot of toolkits in the network. We do like to share things. If you've not stumbled across our website, then please find it. But this is the specific web page to where we've got all the resources. So the toolkit talks about this in a lot more detail and has various different resources you can download, but our wider website also has other links as well, and there's our my contact details on the website. So I'll perhaps put that back on there, and I will have a little look at the questions that we've got. So let's go to the questions. So this is from Tracy. Does the orthoptist delivered inpatient assessment meet the SNAP KPI for screening? There's some confusion within our trust as to whether this needs to be delivered separately to an orthoptist assessment. I don't know whether, Adam, you want to pick that up, or
Yeah, I'll pick up on that one. So it is a grey area, and I know there's a lot of confusion and questioning around this. Due to sort of basically the project metrics we wanted, we took the initiative really to kind of suggest that our screen that we were going to carry out orthoptically is a little bit more of an orthoptic assessment. We basically took it that way. So from our point of view and of the inputters from SNAP from here, we took that an orthoptic assessment was the screen at the time. So we covered it with that one, and they decided to input that an orthoptist seeing them would classify as the screen, as it could vary in terms of how much we did with them as well.
fantastic. I'm going to we've mentioned Claire already, and I'm going to actually switch you on, Claire, so you can speak, and I'll hopefully put your camera on as well. Are you able to speak?
Yeah,
Sorry.
yeah, that works.
Brilliant. There you go.
Yeah. Sorry for butting in. I just thought I'd add a little bit to that. Yeah. So, basically, the British and Irish Orthoptic Society have a consensus statement, and at the end of that, we've produced a SNAP appendix with some national guidance on answers to some of these SNAP related questions, because we held an event with, I don't know whether the questions come from an orthoptist or come from a member of the stroke team, but basically one of the questions, an OT, right, thanks. Yeah, so and I'll put a link in the chat in a minute to the consensus statement, but the national sort of stance on that is that if the screen, that first question, that 613 question, that, you know, the date screened using a standardized tool, that is a non-orthoptist screen. So the response to that is in the document, and so what we should be putting in that is that they've not been screened, and that the reason is organisational issues, because the orthoptist has done an assessment. So and then at 614 that you put in the date that the orthoptist saw them. So basically, if they've not been screened by the team because an orthoptist has already seen them, instead of that, you should be saying not screened, organisational reasons, and then putting in the date of the orthoptic assessment, rather than saying that they've been screened by the orthoptist, because that 613 question, date screened, is screened using a standardised tool. I hope that makes sense.
No, fabulous. I'm going to keep your mic on and your camera on, just because I'm going to switch to another orthoptist question that you and Adam can hopefully.
I'll mute myself.
Do you want to quickly introduce yourself? Because you worked very closely with us on the project, didn't you?
Yeah. So I'm Claire Howard. I'm a consultant orthoptist at Salford Royal Hospital. So yeah, helped to support some of the staff in developing the competencies for the project. And I am part of the Vision Research Unit at the University of Liverpool. So our team was responsible for developing the visa tool, and obviously additional resources and training around stroke competencies for orthoptics. So happy
to put something in the chat, haven't you, already? So people haven't stumbled across that resource. I've got a question from Sarah. A question for orthoptists, so with Adam and Sarah and Claire. It seems the main emphasis is on the management of vision impairment through compensatory approach, provision of prisms, etc. What are your thoughts on neuroplasticity and the role of visual rehabilitation, particularly in regards to diplopia? That one. I don't know who wants to. Do you
want me to take this one first? Yeah. Because I know Claire will have some other parts to put on it as well. From my point of view as an orthoptist, I think this is an area where there's a lot to be sort of gained from, and I think there's maybe a little bit more we need to understand in this area and in terms of rehab. Certainly with diplopia, we use a lot more compensatory approaches, and I think that's correct. I think there is again this grey area where maybe we might be a bit more potentially proactive on an exercise front. This is very broadly speaking from my point of view with it, and there's a lot of different characteristics within that that I think could come out long term depending on additional studies and things as well. But I'll let Claire pick up from there, I think she might have a bit more to say.
Sorry, I was just a bit distracted putting things in the chat. Just let me go back to the question. Was it around neuroplasticity?
Yes, I think so.
In particular for double vision?
Yes. There we go. Seeing the main emphasis VI through compensatory approach, provision of prisms. What are your thoughts on neuroplasticity and the role of visual rehab, particularly in regards to double vision?
Yeah, I mean, there isn't really a huge amount of evidence in terms of double vision and neuroplasticity and rehabilitation. That there has been some ongoing research, and we're hoping to be able to answer the question a little bit more. But basically, what Adam said is, it is absolutely our stance on things. But yeah, we are hoping to look at more of an evidence base, because years ago, orthoptists used to do exercises for double vision and things like cranial nerve palsies, but it's just not something that we have a strong evidence base for now. But watch this space, basically. Some work is definitely going to be done in terms of diplopia.
Brilliant. I'm going to switch now to a question from Kat, who is an OT from Brighton in stroke service there. And this is a question for Kat, actually. Roughly how long does it take to complete the visa assessment with each patient? Do you ever use a briefer screening when you don't have time to complete it all?
So it is obviously dependent on each patient, their ability to engage in the screening, cognitive impairments, things like that. A straightforward screen with somebody who's able to follow instructions easily is probably going to take around 10 to 15 minutes, up to 20 minutes for those that might need a little bit more support to get through the stages of it. So yeah, it is something that's quite quick. We do still use non-standardized assessments. So at times where we've got extreme operational pressures and we might be assessing somebody who could potentially be discharged that day, so a new admission with mild deficits, we would do a functional assessment, a rudimentary visual confrontation, look at oculomotor tracking, those kinds of things, and then highlight on our referrals to our community colleagues that we have not been able to complete a full visa screen, so that can be done and picked up in the community. Obviously, if that person had any significant visual deficits that were impacting on their function, they would be staying in hospital anyway, and then we would screen them on a day where we had more capacity.
Fabulous, thank you. I'm going to move on to a question. Oh, Claire, do you want to come in?
Sorry, yeah, can I just add to that, that if you do a different screen, like a shorter screen, like a VFAST type screen, again, it's in the consensus statement appendix, it doesn't qualify as a screen on SNAP, and you can't put into SNAP that you've done screening using a validated tool. So yeah, absolutely right, it's better than doing nothing to do something and get the referral in, but it doesn't qualify for your SNAP data to be able to say that you've done screening with a validated tool.
Excellent. So deliberately in to drive change. Question for you, Simon. Do you have any advice for seeking ECLO support in other areas of the UK? I think this is the person, Kat from Brighton again. It could be a short answer.
It'd be a short answer. Not a lot, really. No. Seeking ECLO services and support is about getting them in place, and unfortunately, that's a funding issue. So that's the biggest problem for ECLO services, is the funding of them. Once they're in, you're fine, but it's actually getting them initiated.
I'll tie that into a question that Jessica has from Stoke has asked around. Apologies, missed the first slide, but how do you get funding interest from Squire initially, and where do you go from here? I think one of the issues and one of the the problems I have with the pilotitis we have is that very often you're implementing things, and there is a test of change, that's fine, but actually you do know that this should be a commissioned service, and so we spent a lot of time and energy setting this up, kind of knowing that it may not go anywhere at the end, and I don't regret us doing that, but it was a lot of effort. But actually I think in this current world, then you need to be clear, I think, before you try and embark on these things, about what the endpoint might be, if it's going to be a pilot, engagement with the ICB, it being a commissioning priority, or that we've got a regional service. A Stepping Hill provides a regional service on behalf of other residents outside of its own catchment, which makes the funding of things more tricky. But I think you need to have those funding conversations. So I think in answer to your question, Jess, I don't, there isn't a panacea. Anything new that's different, and this is different and new, potentially you would need to find funding from within the provider, the NHS Trust, or some kind of integrated care board kind of decisions that this is something that's needed. Hopefully the toolkit will add weight, and the outcomes we've found that it's worth doing and it has huge benefit. But as I said, we've done the pilot and we've now gone back to not having what we had before. So I was hoping there'd be like a really great ending to this story, and there's kind of a middling ending. It's not as good as we'd have liked it to have been, but I think that's replicated across the NHS. So we don't have ongoing funding, in answer to I think there's another question about that. Let me look and see if there are any other questions. Question from Carl: can I ask, with therapy staff and TIs completing visa assessment where appropriate, did this have an impact on caseload management and minutes provided to other rehab goals related to motor or cognition? His team's concern is they don't have an orthoptist infrastructure, and agreeing to implement the visa tool would impact upon other areas of care that they're delivering. So I don't know whether Rachel and Kat want to pick that up.
Yeah, I can pick that up from an inpatient side of things. So obviously vision is something that is integral to function. So as occupational therapists, we weren't ignoring vision prior to this project. We just now have a lot more knowledge and a lot more focus on it. So it is something that we were already screening with all our patients, albeit not in a standardized way prior to implementation of the visa screen. So in some ways, yes, having to do a visa screen on a patient that you might have otherwise be doing a quick rudimentary assessment on with a fast turnaround in a very busy hyperacute unit would take longer. We're striving to achieve this, even though we no longer have the orthoptist, because it is now been introduced into the SNAP guidelines, and obviously in previous years it wasn't there as a part of our data set that we had to say. So we always try and achieve anything that's added in there to make sure that we're achieving our SNAP standards and gold standard service for our patients. We aren't funded. We did after the project was finished and it became apparent that we weren't going to have the ongoing funding for the orthoptist service. We did submit various funding requests to see if we could have some increased therapy time to be able to, maintain that screening at least for 100% of patients. But again, that has not come into fruition. So we already utilise our TIs for completing MOCA assessments for cognition, so that we were hitting that standardized screening goal again for non-complex patients. So it was something we've added into theirs. But as I said, it is something that slips if we are extremely under pressure. But as we assess vision anyway, the visa just gives us an opportunity to do that in a more formalized, standardized way, so that we're not missing any potential visual deficits.
Anything else to add to that, Rachel?
I don't think so. So what we've seen from the implementation of the project is the massive increase in the standardised assessment being done within the hospital setting. So in terms of the impact on us as a community service, there's not a vast amount of screens that we have to do within the community, because we take the information from the inpatient setting. So in terms of impact on caseloads and on other therapy interventions, as we said before, Kat said before, it's all integrated. So yeah, not a massive impact on our side.
Sorry, I
Yeah.
should just add as well, to sort of quantify that from a SNAP data point of view, our therapy minutes in terms of motor rehab and other areas have actually increased during the period of the project because of other intensity projects we've been doing. So we haven't seen any actual decrease in the data of the number of therapy minutes that people are receiving.
Great. I'm just going to try and finish up the questions we've got here. Could we elaborate on whether there are any specific guidelines or processes that the orthoptist uses for advising patients post-stroke about returning to driving? That's from Rebecca. I don't know if Adam, you want to.
Yeah, I mean, and Claire will be good with this one as well. She's our expert, really. A lot of our guidelines have come ultimately through the BIOS, the British and Irish Orthoptic Society's sort of statement and guides that are on there regarding those. The DVLA does also have a little bit of guidance as well for things, which can be very helpful. But primarily as an orthoptist, we've taken a lot from the BIOS side of things, and I think sort of a lot of our own sort of training around things as well that we've received. So Claire, I'm sure you've got more to say on driving standards than I have.
Yes, you know, it's my favourite topic. Yeah, so the network, the Greater Manchester Network, has a driving pathway in terms of returning to driving. So that's available on their website. So that's something to look at, not just from a vision point of view, but encompassing all areas such as cognition and mobility. So, you know, have a look at that. That is available. The British and Irish Orthoptic Society have a number of resources. The main thing that you need to look at is the DVLA Assessing Fitness to Drive guidelines, which are updated usually around about twice a year. And that's our absolute go-to as for all healthcare professionals, not just vision. Each condition's sort of split out, vision requirements are in there. You can sign up on the DVLA website as well to email alerts, so that whenever there's any changes, and there are going to be some changes, I'm chair of the DVLA medical panel for vision, and there are going to be some changes released in the next few weeks, particularly around vision. So if you sign up to the email alerts, every time there's an addition to the Assessing Fitness to Drive guidelines, you will get that. So strongly recommend as clinicians that you do that.
Fabulous. I have very hurriedly added, and in fact, I've realised I've added our driving webpage. We've got a driving pathway for stroke patients. We've also got one for other neurological conditions because we're a stroke and neuro network as well. And also, I've just realised that Claire, you've got a couple of fabulous webinars that you've done for us in the past. I will make sure that those are loaded up onto the Vision web page that we've got. I'll do that very quickly, and I'll add in the driving link as well, which references another part because it's an important part of our important part of the pathway. I was going to ask Simon, actually, just thinking about charity and support the voluntary sector more generally, and thinking about this project and outside of that, I just wondered if you wanted to say anything around the kind of support that perhaps NHS services need to be better at referring into or signposting to.
Yeah, we know from, so we're quite data heavy at Henshaws because we're quite a big organisation, and a lot of our data shows us that giving out leaflets and information isn't successful. We know that 1 in 3 people might respond to that. So we know that people in a hospital appointment with an ECLO can retain about 2 things. So it's 2 answers. What we're trying to introduce across Greater Manchester with the local authorities especially is direct referral routes, digital referral routes. It's a GDPR headache, but once you get it sorted, it's really successful. We can get patients to opt in, and once they've opted in, we can actually get in touch with them. So it is important to get patients to the service, not to expect patients to get the service to them. We just see this with lots of people with sight loss. So that's the key thing. And the other thing is to actually involve your local sight loss charity. You know, that's another key part to it, because if you don't involve them, they don't get the opportunities and they'll disappear.
Yeah, and I would say that wholeheartedly, not just around visual impairment, but we need to get better in the NHS about looping in and linking in with our resources. I think certainly in the 10-year plan and the move to locality-based, place-based care, there's lots of work happening at a neighbourhood level that we need to engage with. Community teams are very used to doing that and need to be encouraged to do that. But I think when you're developing a pathway of care, do not forget your voluntary sector partners, because they are often funded and they're often there, and we probably don't use them quite as much as we could. I think I've scanned the questions and I can't see any more. I think in terms of resources, most of the links and things are in the chat, which obviously you can take a look at afterwards. I'm going to quickly now go to our webpage and put the links into the presentations that Claire's done in the past, and also I'll add in the driving link. Can I ask that people do evaluate this webinar? We sent out a link asking you to sort of link to say how much you understood and how confident you were before today's webinar, and also we've got a little QR code in the chat around your what you thought about the webinar, and also about your confidence and understanding afterwards. So please, can you make sure that you fill that in? We do look at them all and we do use it to inform our future events. So I think, unless there are any more questions, which I can't see that there are, I'd like to thank our presenters today from Sepping Hill Hospital and also from Henshaw's, and also for Claire Howard guesting as our expert. We're very fortunate to have her within our our stroke pathway, and is also a good resource. Hopefully today, although it wasn't quite the full happy ending that we were hoping for when we started the project, you can see that there are massive benefits to focusing on vision impairment. And I think your journey might be long, but please don't give up. Obviously SNAP provides some kind of impetus to drive some of these things forwards, but it's also, I think, maybe around getting the patients and carers themselves to perhaps articulate the need. I think sometimes we rely on business cases that are quite dry, but I think it's around getting people to understand actually what the impact of not having a diagnosis of a vision impairment and how that really impacts both your recovery and the length of time you might spend in services, which potentially more, but also about how you go about your life and things like your job and driving, etc. So I think it's a hearts and minds exercise. I know that we're all potentially happy to take questions. I've put my email address at the end of the slides. We will make sure that, I think today actually we might get the recording edited and sent out to you with the links and things on. And so hopefully it's been useful. And once again, thank you to our speakers today, including, I think, Farheen, who is lurking, who did an awful lot of the work on this project and really made it happen. So thanks for coming today. And we might see you at a future event. Take care. A bit waffly at the end.